Good morning, everybody. Thank you. I have the pleasure of introducing the first speaker and someone I don't think anybody needs an introduction to, Dr. Janak Nathan. I think all of us know him very well, but for the young ones or the new people who are joining this program for the first time, Dr. Nathan is a consultant neurologist at the Shushrusha Citizens Cooperative Hospital. He's also an honorary professor of the D.Y. Patil Medical College and Hospital Research Center. He is a member of the ILAE Task Force for Dietary Therapies and is the organizing chairperson for this workshop that we have, which was meant to start with one nation, but I think has now spread over an international field with not just Southeast Asia, but members from other countries as well. He is Asia's pioneer for the ketogenic diet for epilepsies, cancers, and other indications, neurodegenerative disorders for the ketogenic diet. He was the founder of the Epilepsy Care, Vijay Epilepsy Care Foundation in '96 to spread awareness of epilepsy and the ketogenic diet. And he's an Asian member of the executive committee of the International Neuroketogenic Society. Now, not only does he have numerous publications, but he has numerous books, which many of our patients get on recipes and everything about the ketogenic and how to deal with the issues that come across. But the one thing that I would like to highlight with Dr. Nathan is his perseverance and dedication to the concept or to the ketogenic diet. In 1996, when I was still just starting my career in pediatric neurology, it wasn't as well accepted and wasn't as well, people were not so willing to be so tolerant towards this non-allopathic treatment. And since then till today, Dr. Nathan has persevered and has sincerely put all his efforts into the ketogenic diet. And today we all accept it. It's internationally accredited. And you can see from the program today with 1,000 registrants on the ketogenic diet, Dr. Nathan, congratulations for your perseverance and welcome everybody. And let's hope we have a lovely session for the 2 days.
Yeah, good morning, everyone. I'll just try and get only the speaker view. Anita, would you put off your video for some reason?
I have, it's already off.
Okay.
On our screen, it's only you.
Okay, fine. So welcome all of you to the ILAE workshop of 2022. Thank you, Anita, for that introduction. I think it's a little overboard. I don't think I'm all that great. So let's see. Let me. Are you able to see the entire slide, or the speaker view is also being seen?
No, just the entire slide.
Okay, I think we need to get the speaker view. I'll just try and put that in. Sorry for that. Let's get it such that. Now, are you able to see me also or no?
I can see you as the speaker at the side.
Okay, great. Because I can see Anita Hegde over here. So as all of you know that it's 100 years, actually KD has been 101 years, and the fasting has been around for 2,400 years, and now it has spread its wings. So it began with Hippocrates in 400 BCE, before the Common Era, who talked about purging and fasting and how he had cured one of his patients. Then the Bible also mentioned that in the New Testament, Mark, how prayer and fasting could cure epilepsy. Hippocrates really was probably even further than us right now, because he talked about purging when we did not even think that cleaning of the bowel could change epilepsy. So the fasting was then used by doctors in 1911 in France by Guelpa and Murray, and then in the US by Hugh Conklin in 1921. But it was Wilder in 1921 of the Mayo who really talked about what is much later, that is 100 years ago, and Dr. Freeman, who really has introduced us back to the ketogenic diet, which almost had died out. So from 1921 to 1996, it took 70 odd years to reach Asia, and now it has spread so rapidly throughout Asia. So that was Hippocrates, who said that this disease is not sacred, and he cured one person. That is the Bible, showing you a painting by Raphael, which is in the Vatican, and down below on the right side corner, you can see the boy with the seizure and who went to Jesus because the doctors around could not help him. And it stopped with prayer and fasting. But the history of anti-seizure therapy has really been the anti-seizure medications. The first generation, the second generation, and the third generation. So the first generation could control about 65%, but the second and the third generation combined have only added another 5 to 10%. So the natural history of epilepsy is that if you take anywhere, whether you go to a rural village or whether you're in the Johns Hopkins or in the Mayo, 40% of all patients will be controlled on the first anti-seizure medication. Second, on if you need a second, then another 20% or so. And if you need a third or fourth, another 8 to 10%. So that anywhere in the world will leave behind 25 to 30% who are uncontrolled. So the history of the ketogenic diet really begins with Galen, when he reported this in the American Medical Association, that an osteopath, Dr. Hugh Conklin in Manhattan, was using fasting for 15 to 25 days, and 18 of his 26 patients improved. But then Dr. Wilder realized that you cannot go on endlessly with this fasting. And so maybe he said you can get ketonemia by other means, that is a diet rich in fat and low in carbohydrate. Peterman then put it into a mathematical concept, and this is almost like the 4:1 keto diet ratio that we use now. But once drugs came, and Dr. Merritt was the one who discovered phenytoin, and what he said is very, very pertinent, that I have done the greatest disservice to epileptics with the discovery of phenytoin, because with this, the research into metabolism of epilepsy and mode of action of ketogenic diet would stop. Very, very pertinent. He could see so far into the future, because even the metabolism of epilepsy people didn't look at. And then with the host of anti-seizure drugs that came, interest in the diet declined, except, and I must say, we owe it to Dr. John Freeman and his dietitian, Millicent Kelly. I was very lucky to be invited over there, and I was very lucky to work with him. Just by the side, when I told the others in the Johns Hopkins neurology department that I would like to work with Dr. John Freeman, I looked around for about a week, and then I found that I was not interested in the others, including epilepsy surgery, because that's a very, it's tedious, it's expensive, and I don't think everyone can afford that. So I told him I'd like to work with Dr. John Freeman, who I think is doing some very good work and very simple methodology of controlling uncontrolled seizures. And really, they all told me, be very careful. He's an old man. He's very eccentric. I mean, I don't know what he's doing. And we don't know whether this treatment is really good or it is just, hullabaloo and momo jomo. That's what they said. Then we got help from Charlie in 1991, who had uncontrolled epilepsy, 100 major seizures a day, and was told by his doctors that nothing can be done. Luckily for him, went to Dr. John Freeman. He said, try it. And it's history that he is now okay. Jim is a Hollywood and TV producer, produced The Dateline, was a biopic sort of thing, very short one, and then made a full-length movie with Meryl Streep and Millicent Kelly. And that really took off. He then set up the Charlie Foundation with all his money donated. And you can see Charlie as a young adolescent and Charlie in 2012, and I'm with my mentors. I owe everything to them. So we have treated now over 600, and we have trained keto teams from all over. But let's see what it does. We'll put just two cases. This boy came with doses, many head drops. He used to bang his head, and therefore he had two bumps on both frontotemporals where he would bang his head. And not only with that, he lost his speech, he lost his eye contact, he lost his recognition of his parents. So the mom's reaction was all hell broke loose. Luckily, he came to us within 2 to 3 months. They read somewhere on the internet, they came to us, and within 3 weeks, he was seizure-free. And the mom said, thank you for having given back Ara. Why did no one tell us about his diet earlier? Today, this boy is in the 8th standard, and he's doing very well. However, some of them respond late. And here we have a child who had 75 to 100 major seizures a day, just like Charlie, and now is off the diet and enjoying normal food. However, she came to us late. She came to us after 2 to 3 years. And she had at that time 30 to 40 seizures every day, major seizures. She had to be put on the ketogenic diet for 7 years, because even though her seizures were completely controlled after, I think, 3.5 to 4 years, her EEG took another year or so to normalize. And then we kept her on for another 2 years. Of course, her medications we could withdraw earlier. However, because of this long period, she is not educable. She walks, she runs, she plays with her toys, she likes music and watches the TV. So the moral is, please start the ketogenic diet as soon as possible. She was put on 7 to 8 anti-seizure medications before she came to us. And we know that beyond 4, there's really nothing much that you can do as far as medications are concerned. So why has our diet gone wrong? Let's just go back and look at it and see that 200,000 years ago to 11,000 years ago, they were hunters and gatherers, mainly eating protein and fat, which was stored, fermented, or cured. And only in the summer, they were gatherers. And then came agriculture 6,000 years ago, where we had processed food, ground food, polished food, refined food, and gradually went into packaged food with a lot of pesticides, insecticides, water, and food. In the first, you see right down below that they had frequent periods of fasting intermittently because food may not be available. So their fat was really 40%, the protein being 30, and the carbs being another 30. And then it all changed. And the 40% fat became in Indian and Eastern diets, 15%. The carbs went from 30% to 60%. In India and Eastern, and the carbs in the West is at around 50%. So we shifted and we started eating less fat, more of carbs, more of processed food, more of packaged food. And that became the modern diet, along with sedentary life, food binging, snack couching, and the gadget guzzlers. And obesity zoomed up. This is only till 2014. It zoomed up even more. Asia from 1% has now gone to over 11 to 12% obesity. And that obviously causes a metabolic syndrome. So our diet, and I'm going to briefly talk to you about what is the ketogenic diet. So this is our normal diet where you have a lot of carbohydrate, less of protein. If you are non-vegetarian, you have a little more of protein. If you're purely vegetarian, it's a little less, and fat is always the least. And the carbohydrate is mainly used for energy production. However, any excess carbohydrate is not stored as carbohydrate, but is converted into fat and kept in an energy depot, which is mainly fat. So on the top is your food, nice, beautiful, as we call it in India, a thali with a whole lot of food items. But look at the carbohydrates. It's so heavily loaded towards carbohydrate. And that's what we use every day for our day-to-day purposes. If you fast, then you can shift the liver down below and take out a little bit of carbohydrate which is there. But after 2 to 3 days, even that's over, and then you switch to your stored fats or ingested fats. So when you are in a fed state, your carbohydrate is being converted into glucose, but when you are in the fasting state and your liver glycogen or carbohydrate reserves are over, you will pull out either your stored fat or the dietary fat, and that is converted in the liver to ketones. So it's only when there is limited carbohydrate supply, so that's very important, limited carbohydrate supply, that the liver will, after using up its glycogen stores, go into the fat and pull that out. So this is just an introduction. I will now go straight to the next, and that is what is the mechanism of this ketogenic diet. So I believe that the keto diet is the diet of the 21st century. It has changed the way we look at diet. In order to know how it works in epilepsy, we have to know what is epilepsy and what is a seizure. I'm again going into the basics because there are a number of non-medical personnel, mainly the dietitians and the nutritionists, and there are even some of the caregivers. Sorry. So what is a seizure? It's an abnormal electrical activity in the brain which results in abnormal body movements or a change in behavior. And anyone can get a seizure. You can get it, I can get it, all of us can get it. If I stay awake for long enough, I can get it. If I take certain drugs, I can get it. If I take the recreational drugs, I can get it. So epilepsy is not just a seizure. It is an enduring predisposition to generate epileptic seizures spontaneously. So it is the development and extension of abnormal tissue which can generate spontaneous seizures and then either develop into an epileptic condition immediately or progress over time into epilepsy or seizures. So it's a gradual process by which a typical normal brain develops epilepsy. Develops is important. So how does a seizure occur? There's an action potential. There's a role of sodium and the potassium channel. Sodium enters, there's depolarization. Then there's repolarization when potassium leaves. There's a hyperpolarization when the cell is not excitable. And then it comes back to its resting potential. And on the EEG, that is a normal EEG first. Second, you get these spikes because of this sodium and the potassium movement. And then if there are too many spikes and there are a train of spikes, you will get what is known as a seizure or an ictus. Down below in B, you will see that there are two types of cells. The main cell is the neuron, and it can be excited, what by another cell known as E. But that same cell number 1 can excite an interneuron, and that interneuron could be inhibitory. So basically, it is a balance between excitation and inhibition. And if that is lost, then you can get a seizure. So this is what you can see, depolarization when there is influx of sodium into the cell. And then there is repolarization where there's an efflux. So the influx, and if it is abnormal, which is what happens in a seizure and then in epilepsy, it results in a prolonged neuronal hyperexcitability state. And when there's an abnormal potassium channel, which becomes slow, the efflux is slow, you can again get abnormal activity, and that can be a seizure. Along with that, you have inhibitory transmitter known as GABA, which also is acting. The calcium ions act in that. They have a GABA receptor, and they cause inhibition of the neuron. On the other hand, you have excitatory, the glutamate, which acts on 2 of the receptors, an NMDA and a non-NMDA receptor, or on AMPA. So along with just the sodium and potassium, which are the, and the calcium now I've introduced, you have 2 neurotransmitters. So now I'll have to go a little more fast. So the glutamate is excitatory. The initial impulse is through AMPA, another chemical receptor, and the NMDA receptor, the initial and the delayed, which causes excitation, depolarization, and promotes firing. On the other hand, you have inhibition through interneurons, or the GABA, which can cause hyperpolarization and suppress the firing. But there are astrocytes in between to make things worse, that they can then cause excitation of the neurons. So it's not that simple. But ultimately, all this results in change in ionic channels, neurotransmitters, namely GABA, glutamate, and AMPA, and a loss of the after hypopolarization, which will keep the cell in an inhibited state, loss of surround inhibition, excess glutamate stimulation can cause excitation, and an increase in intracellular calcium. And all these can cause recurrent excitatory feedback circuits feeding on one another and causing multiple seizures one after the other. So I've told you already about this and how a seizure differs from epilepsy. But more important is that the mechanism. You just can't get a seizure. You have to have some trigger, which triggers out the whole thing. And some of them are traumatic brain injury, stroke, febrile seizures, hemorrhage, status epilepticus, genetic malformations, neurodegeneration, neurogenesis, gliosis, the blood-brain barrier dysfunction, inflammation, the channelopathy, the molecular alteration. These are the triggers. That's an initial insult. And then after that, you have epileptogenesis. So the initial insult can be repaired. And that could be done by metabolic therapy. Then there's a latent period where you have development of the epilepsy, which could be months to years. Again, that can only be prevented by a metabolic therapy. So repair of the insult, prevention of epilepsy can be done only by a metabolic therapy. While seizure suppression, once you get your epilepsy, you are suppressing seizures. Actually, you have anti-seizure medication, not anti-epileptic. It's unfortunately still being called as anti-epileptic drugs. Then they're not anti-epileptic, they're anti-seizure. So modification of this disease can only be done by the metabolic therapy and the role of potassium in the kindling. So what we talked about in the middle, the initial insult, the latency period, and the epilepsy actually is known as the kindling, where in the last line, once again, please read that, normal surrounding neurons are co-opted into the seizure activity. I hope now all of you realize that the longer you take to put your patient on the ketogenic diet, once 4 drugs have failed, the longer are you going to take to be able to control them. Now, this is very, very important because that is known as the kindling. So in very simple terms, there are two main drugs, glutamate and GABA. Excitatory glutamate, inhibitory GABA. If GABA is less, the potassium channel activity is reduced, the synaptic activity is reduced, and you can get a seizure. If glutamate is more, the sodium channel activity increases, excitatory synaptic activity increases, network activity increases, you can get a seizure. And the ketogenic diet balances this. So that's the very simple. So how do you get ketones? Ketones are substances produced naturally from fats, known as ketogenesis, and ketolysis is the breakdown of the fat for energy production. So ketogenesis is controlled by insulin glucagon occurring in the liver. I'll go over this. I'm coming straight here. So you have fatty acid oxidation in the liver through the HMG-CoA, which is available only in the liver, beta-hydroxy beta-methyl glutarate CoA, and you get acetoacetate and beta-hydroxybutyrate. Now, unfortunately or fortunately, the liver can't use this because it does not have something known as a SCOT. So this thiopherase or SCOT is absent. And because of that, it cannot be used in the liver. It comes out into the blood, and the muscle and the brain can utilize this. So conversion of fats is being controlled by insulin and glucagon. When you're in a fasting state or a low carbohydrate intake, the glucose levels fall. So there's a fall in insulin, rise in glucagon, mobilization of lipids known as lipolysis. So that's your ketones will be ultimately formed through what is known as ketogenesis in the liver. The difference in two, very important, is that the medium chain fatty acids can easily enter the mitochondria, and the long chain fatty acids require carnitine for entry through the carnitine palmitoyl transferase. Once you have ketones being formed, which are these three, you then go on to ketolysis, where the ketone bodies are going to be now used for energy by the mitochondria in all cells except the hepatocytes. And these are very easily absorbed because MCT1 is available universally. This adaptation is controlled by hormones. I've told you about that. Also transcriptional proteins, PTM modifications of key enzymes, and the biochemical. And this shows you in a cartoon how the ketogenic diet, you get fatty acids, that goes into the Krebs cycle. Before that, you're getting beta-hydroxybutyrate acetone. Since it's not the liver is unable to use this, the fatty acids and the ketones come out. The ketones are used by the mitochondria, especially in the brain. And the brain can utilize for its energy, it can get 75% of its energy from the ketone bodies, 75% of its energy. And as all of you know, right now, all those who are listening to me very attentively, 50% of your glucose is going to your brain. The brain is using up 50% of your glucose. Those who are drowsy, maybe 25 to 30%. The difference between MCT and long-chain fatty acids is important to understand, that the long-chain fatty acids have to go through the chylomicrons, the lymphatics, and then get deposited in the lipid stores, from where it is mobilized only when the carbohydrate is low, while medium-chain triglycerides can go through the portal vein into the liver and get mobilized much more easily and get converted into ketone bodies much more easily. So that is the difference between MCT and LCFA, the long-chain fatty acids. MCT does not need the carnitine in order for it to be utilized. So ketone bodies are produced only in the liver. I'm going through this very slowly because once you understand this, you understand the rest. Through something known as the HMCG enzyme, They're unable to use the ketone bodies because they lack SCOT. So therefore, they are exclusively used in the mitochondria of the others, that namely the muscle, the brain, etc. It's very important for cancer control here because the ketone bodies can only be used by mitochondria, and where cancer cells, as we all know, their basic problem in a cancer cell is a deficient and disturbed mitochondrial metabolism. So that's the balancing act, and that I've talked to you already, how the mechanism was. And as you can see, anti-seizure medications mainly acted on sodium channel, potassium channel, GABA, and glutamate. And they either enhanced inhibition or reduced excitation. And over here, you can see in this huge table, but just see what's on the top: sodium channels, calcium channels, potassium channels, GABA, glutamine. The only medication which is not exactly the same is the SVA2, the levetiracetam. So anti-seizure medications are neither curative nor preventive. They have no effect on the epileptogenesis. They have no prophylactic effect. So we have to find something else, because the recurrence rate after withdrawal is 25 to 30% in non-IG and 20 to 100% in idiopathic generalized epilepsy. IG is idiopathic generalized epilepsy. So I've talked to you about how they're going to be uncontrolled. So what do we need? We need something that stops the seizures, but also halts epileptogenesis, prevents recurrence, repairs damage to the brain, stimulates the stem cell, reduces the triggers of acquired epilepsy, and reduces the genetic causes of epilepsy. And ASMs don't do this. I call this as the iceberg phenomenon. We are just on the tip of the icebergs, and that is it. The traditional drug targets only the G protein coupled receptors. Those drugs haven't yet come out into the market, but they'll come out soon. The ion channels and the protein kinases. But what's below the surface of the sea is the main part why you get epilepsy. The primordial metabolites, adenosine and ATP. The biochemistry, namely the DNA, the RNA, the peptides, and the proteins. The bioenergetics and the metabolism, and the DNA and the epigenetics. This is what is causing those insults to your brain to ultimately convert into epilepsy. Everyone with a head injury does not get epilepsy. Everyone with a paralytic stroke does not get epilepsy. Everyone who gets an infection of the brain does not then go on to get epilepsy, even if they get encephalitis. So it's these which cause it, and that is very unique in every person. And can we do something to halt epileptogenesis and of course epilepsy? So the dietary therapies are the ketogenic diet, the classical, the variants, MCT modified Atkins, the low glycemic, and namely 2DG and ceftriaxone are coming in. So the types of diets are put here, and you can see that the main difference between the classical ketogenic diet and the others is that the green increases, that is the carbohydrates increase, and the yellow or the fat decreases. So the ketones rise in normal diets in the classical and the MCT ketogenic diet, where you have MCT along with the ketogenic diet. The blood glucose falls in both classical and MCT. In the modified Atkins, the blood glucose falls mildly and the ketones very mildly increase. In the LGIT, there's hardly any increase in blood ketones, and the blood glucose also is not very low. So what are the targets for epilepsy control? And I put only one in red: neuroinflammation. There are ion channel dysfunction, there are structural pathologies, there's a molecular disruption, there's stress, there's hormones, neurotransmitters, immaturity of the homeostatic mechanisms, altered metabolism, and the gut microbiota is very important nowadays. So how are metabolic therapies different, and are they anti-epileptic? They restore the impaired bioenergetics and mitochondrial function. They improve redox regulation. So what is redox regulation? Is the oxidant-antioxidant balance. Oxidants are being formed all the time. You have to remove that every day. And that is improved by the ketones and by metabolic therapies. Regulation of both excitatory and inhibitory neurotransmission. the glycolytic restriction, the signaling pathways, especially the mTOR, the PI3K, and the AKT. So these pathways can be modified by metabolic therapies. Plus, they have a direct and indirect anti-inflammatory action, both on the neurons and the blood-brain barrier. And the last and most important, they have an epigenetic effect on the DNA and the histones. So this is the basis of the disease-modifying effect and the anti-epileptogenic effect. And this is how they work on inflammation, epigenetics, gliosis, calcium homeostasis, ROS, ATP, apoptosis. So they're really acting on all of these. I'm not going to go into the details of this, but I'm going to tell you very important is that inflammation seems to be a very major trigger. Then you have the kindling, then you have the cells in the brain, and then ultimately you have epilepsy. This is also very, it's a very detailed thing. So let's not go into that. Initiating event, you can repair, then you have nothing. If you fail to repair, then you can get epileptogenesis, or the initiating event itself can cause seizures, but not go into epileptogenesis. And then you have a latent period in pink, which then causes spontaneous seizures and the cognitive behavioral disorders. And then it can progress into epilepsy and then into the chronic epilepsy. So really the anti-seizure medications is the last red square you're seeing down below, where you can only suppress seizures. But you cannot modify the initial insult, and you cannot modify the disease or the anti-epileptogenesis. So the other very important, other than inflammation, is glucose hypometabolism, which triggers network hyperactivity, oxidative stress, that's your oxidant, antioxidant, ROS, reactive oxygen species are being produced all the time. And that then feeds into the seizures. The seizures in turn cause glucose hypometabolism and more ROS. So it's a vicious cycle. So the PET scan is showing you inflammation, and that in the B, A is showing you red inflammation, B is showing you glucose hypometabolism. The same thing on the FTG PET and the glucose hypometabolism is blue. The red arrows are showing you blue. So that shows that there is glucose hypometabolism. That is, the cells are unable to utilize glucose. If glucose is not being utilized, obviously the cell is going to suffer because that's the main source of energy. So this has shown that there is abnormal glucose metabolism. We don't know how, but we know that that could increase glutamate and cause abnormal mitochondrial function. And ketone will act as an alternative fuel and help us. So this in short will show you everything, but I know most of you are going to be too overwhelmed by this, so I've tried to break it down. So epilepsy is due to excitation, the neurotransmitters on the top, lack of potassium ATP channel activity, inhibition, the GABA B, and the sodium channel. So the sodium channel, ketones plays a very important role in two pathways of the sodium channel, and they can directly alter the nerve excitability or also have a neuroprotective effect. That's the effect on the sodium channels. The potassium channels, they maintain them in the open state and cause a decrease in neuronal excitability. So on the potassium channels. So they cause membrane hyperpolarization along with the low glucose. So both. The low glucose also causes this and the ketones also cause it. Then the NMDA and the GABA receptors. So what does it do? GABA is the major inhibitory neurotransmitter I told you. And the synthesis of GABA is increased by ketones, and the CSF levels in GABA is increased when you put a patient on ketogenic diet. So more GABA, more inhibition. Glutamate, the presynaptic release of the glutamate is reduced. The transport of glutamate is reduced. Reduce glutamate, reduce excitation, reduce seizures. So it acts on glutamate also. It also acts on AMPA. So AMPA, as I told you, if you remember, is the initial excitatory, the receptor which causes an increase in the glutamate. And ketones inhibit AMPA directly. Decanoic acid a constituent of MCT, now this is very important, it also directly inhibits AMPA. So MCT has an action independent of the ketones. What are the other targets? Mitochondrial biogenesis, you need more mitochondria. The glucose hypermetabolism we talked about. The free fatty acid receptor 3, anti-inflammatory effects, antioxidant effect, the gut microbiome, the MPTP, that is the mitochondrial pore transmitter, the anaplerosis, that is getting back your or refeeding of your cells in the brain, the epigenetic modifications, important the BDNF and then the adenosine. It also acts on two which you are seeing in the site, PPAR alpha, PPAR gamma, and the NLRP inflammasome. I know, very, very difficult, very, I'll try and do something with that. Mitochondrial dysfunction will lead to more ROS. And ketones will reduce ROS and reverse the mitochondrial impairment, and it will block the mitochondrial permeability transmission pore. And that is one of the reasons why calcium enters. So thus it causes a consistent anti-seizure effect, anti-inflammatory, both by reducing glutathione, NRF2, and the UCP, and also through the PPAR and inhibition of HDAC. So there are multiple methods by which it is anti-inflammatory and antioxidant and reduces ROS. ATP, obviously, every cell needs, and that is increased by ketones. And it enhances mitochondrial ATP by an increase of NADH. It also increases adenosine. The synthesis and release is important. Okay? And it through all these methods, it can reduce excitation of the cells. On the free fatty acid receptor 3, it can be blocked by BHB, and this is important in tumor proliferation, tumor invasion, tumor metastasis, and to reduce all of these, but also angiogenesis. Now, angiogenesis is very important in epilepsy, which is secondary to head injury, cardiovascular accidents, and of course, the cancer control. So what about epigenetic modifications? There's a hypermethylation of the DNA when you have epilepsy, and there are histone acetylation changes with epilepsy. So both of these are epigenetic effects on the ketones. And hypermethylation and histone acetylation comes from endogenous and exogenous effects on us, on our brain, on our body, which include pollution, radiation, what have you. There are a whole lot of things that does this. So they act as an inhibitor of the HDACs. There's a chronic firing of neurons, and therefore the neurons have diminished ATP. So ketones, through non-glucose sources of energy, which is known as an anaplerosis, is replenished. So you're replenishing metabolic intermediates so that you get more energy into the neurons. BDNF is linked to AMPK and mTOR, and the mTOR is a regulator. It has effects on epileptogenesis, mitochondrial biogenesis, and on the brain plasticity. So it promotes the growth and survival of the neurons which protect against stress-induced apoptosis, synaptic plasticity, and cellular stress resistance. This is very important for not only limiting seizures, but reducing epileptogenesis. The MCT has a different action. It has a separate direct effect on AMPA. The problem is due to the GI side effects. Ketones now has an effect on SIRT1. And what is SIRT1? It's increased by ketones. SIRT1 repairs your DNA damage. Do you know that every cell undergoes 24,000 DNA damages every hour? And that is being repaired by SIRT. And if you don't have adequate SIRT, which happens in people who are old age, Alzheimer's, neurodegeneration, etc., you're going to have a big problem. and SIRT1 will repair the damage, which is also seen in epilepsy. Angiogenesis, very important, new blood formation, as I told you, for head trauma, stroke, and then your angiogenesis or new blood vessel formation. BHB is anti-VEGF, that is your beta hydroxybutyric acid, which is a ketone. It reduces epileptogenesis and the tumorigenesis. The gut is very important. There are 1,000 different species of bacteria in your gut, along with viruses, etc., and they are run into trillions. It's been found that seizure susceptibility can be modified by the gut microbiota through the vagus nerve, through cannabinoid, and through cytokines. And it can decrease it through short-chain fatty acid synthesis and through neurotransmitters. So a change in the gut microbiota or dysbiosis can give rise to epilepsy. And in fact, persons with epilepsy have a difference in their gut microbiota. Not only that, those who have drug-sensitive epilepsy and drug-resistant epilepsy, again, there's a difference in the gut microbiota. So therefore, you can reverse this by dietary changes, namely the ketogenic diet. So it's very important. Keto microbiota can cause, through the gut, epigenetic changes. I've talked about that, and metabolic reprogramming. And that is the pathogenesis of not just epilepsy, but neurodegenerative diseases and cancer. This is in the pipeline: alpha-linolenic acid, bezafibrate, and caffeine. But we have to really look at it more carefully, and maybe we can co-administer that with the ketogenic diet. So therefore, the ketogenic diet is not only anti-epileptogenic, anti-convulsant, and neuroprotective. So the multifarious actions of ketones, as I have told you, there are many. And that is a summary, again, very involved, but basically showing you that there can be neuroprotection through various means, including LGI, modified Atkins diet, ketogenic diet, MCT ketogenic diet, and calorie restriction. And these are the methods how it works on neurotransmission, metabolism protection, neuroprotection, inflammation, the genomic effect, and mitochondrial regulation. Now, Anita, can I take another 5-10 minutes?
Sure.
Because we began, I think.
Yes, please go ahead.
So I'm just going to touch on two other topics here. One is on the autism spectrum, which all of you know it affects many. It has a huge spectrum. Ketones, how does it act in autism spectrum disorder? It's an antioxidant. It's neuroprotective. It acts on the GABA. It acts on the cholinergic system. Both of them are disturbed. The mitochondria are abnormal. You get new mitochondria, and you can repair your mitochondria. In the mitochondria, one of the ways by which you get energy is through something known as an electron transport chain. That's the place where you really get most of your ATP. The TCA cycle or the Krebs cycle and the ETC change or the electron transport chain. It works on that. It works on beta oxidation. It works very well on pyruvate dehydrogenase effect, abnormalities, which Anita will be speaking on. It has an effect on the energy sensing pathways. And the most important in ASD, I believe, is its action on the gut microbiome. So the gut microbiome has a very great influence on autism. And we know that there's a big difference between those children born through the vaginal route and those through the cesarean route. And there is dysbiosis in between, a lot of it, and that can cause a whole lot of changes in the child because it increases inflammation. It increases pro-inflammatory cytokines. And the ketogenic diet, we know, acts on not only that, but also on not only on the microbiota, but also on inflammation. And the last is the cancer. I've talked to you a little bit about that, but I think this is very important. Cancer today should be treated as a metabolic disease. It is not genetic. Genetic comes later. It's basically metabolic. And the cells of the cancer are different from us. Louis Pasteur, hundreds of years ago, showed us that our cells, when they utilize glucose, you get carbon dioxide and water. Cancer cells will use the same glucose and convert it into lactic acid, known as the Pasteur effect. 1820s to 1890s. Imagine that man is the one who talked of germ therapy, pasteurization, vaccination, and he showed that the cancer cells are metabolically different. Warburg went on to show that because the mitochondria are different, and look, this is what happens. Glucose outside of the mitochondria, the oval in the center is the mitochondria with the crenated inner surface. So outside of the mitochondria, you get only 2 ATP from glucose. Inside the mitochondria, through the TCA cycle and through the electron transport chain, you get 36 ATP. So therefore, if your mitochondria are not working normally, if they are damaged, as in cancers, you get only 2 ATP. So you need 18 times more glucose. And this is what was shown, that normal cells, when multiplied, give normal cells. Tumor cells give tumor cells. But if the abnormality was to be in the red nucleus, which you can see in the tumor cell, take that red nucleus out and put it into a normal cell. The mitochondria are the green sausage-like things you can see over there. That is where you get your energy from. The genes are in the nucleus. So if you put abnormal cancer genes into a normal cell, and if it was genetic, you should have got cancer cells. But you don't, you get normal cells. But if you keep a cancer cell, leave those abnormal mitochondria, and just remove the abnormal genes in the nucleus and put normal genes, those don't do anything because the mitochondria are abnormal, you get tumor cell or death. And Dr. Seyfried, I must salute him. He's a biologist and he has really worked on this field. So the targets in cancer again are many. I'm sorry, did I skip a slide? No. So the mitochondrial metabolism, the cachexia, anti-inflammatory, the gut microbiome, angiogenesis, altered genes, pro-apoptosis, and increased autophagy. And you can see, I spoke about all this earlier. And this is where it works. So the ketones work on so many areas of the cancer. So the cancer, the Warburg effect is that it has to use glucose. It's highly dependent on glucose and glycolysis. So when you cut down the glucose and we bring it down to around the 70s and increase the ketones, your body is very well fed by ketones, but the glucose can't utilize those ketones because of the abnormal mitochondria. They also enhance oxidative stress response and therefore reduce the ability to synthesize NADPH through the PP pathway, pentose phosphate pathway, because the mitochondria are abnormal. There's also damage and defect of the electron transport chain. You get more reactive oxygen species. The concentration of reactive oxygen species will rise and therefore they will die. That means they will be killed. So that's how the ketogenic diet works. It also works on this IGF-1, PPAR, and mTOR pathways. Because if you can block that, and that's what happens, you can block these, then your tumor cell, the proliferation will become less and the inflammation will become less. It also works on the abnormal glucose metabolism of the cancer cells. I won't go through it, and the abnormal mitochondrial metabolism of the cancer cells. It also acts on SIRT1, and if you have more SIRT1, you cause apoptosis of the cancer cells. It targets angiogenesis, vascularization, and the tumor environment. It targets inflammation through the NLRP inflammasome. That was Simon. And regulates gene expression in the tumors through the HDACs and the DNA methylation. So there are a number of methods. And of course, I talked to you about the gut microbiome. It produces short-chain fatty acids, which is very important in cancer prevention and treatment, and suppresses the glucose metabolism. Very useful in called colorectal cancer and enhances the effect of chemotherapy. So therefore, the spectrum of the ketone therapy, as you can see, is increased from just epilepsy in the brain to so many conditions in the brain, to cancers on the other side, the gliomas, especially we are interested, but in many other types of cancers, in metabolic syndrome like obesity and type 2 diabetes, and in organ failure. And that's where it's going to come in very useful. We know that non-alcoholic fatty liver disease and non-alcoholic steatohepatitis, no treatment available except transplant. And that's where it works. So my eternal thanks to Dr. John Freeman, Miss Millicent Kelly. Because of them, I am where I am. I thank all of you, and I will now stop sharing. And I just tell you that we have what is known as the Asian Institute of Ketogenic Therapy. The questions.
I've already given to Dr. Anita.
And I've stopped now. And Anita, I am handing over to you. Thank you very much. Thank all of you. I hope it is, I know it was very, very involved, very extensive. But I think this is something that is very useful to all of us. Thank you very much.
Thank you, Dr. Nathan, for a very exhaustive yet fascinating talk. Before I make a short synopsis of this talk, could I request everybody to put your questions into the chat box so that we can ask Dr. Nathan? You very nicely explained the understanding of epilepsy, the difference between anti-epileptic and anti-seizure, very important aspect. A nice take home was the early ketogenic has very good outcomes as against late, because you silence the generator, which leads to better, not just seizure outcomes. You highlighted the understanding of how ketones actually work in the diet, the balance between glucose, ketones, the different diets, the MCT, the LGID, all the different variants that you have. The concept of the anti-inflammatory, and thus I think its role in other indications becomes more widespread because of the role of the anti-inflammatory. The understanding, I learned so much, the understanding of its role in the mitochondria as an antioxidant, ATP, the SIRT1, that was fascinating as well. But to me, the most interesting was the last bit, the autism part and the ketogenic diet, and it's given me lots of ideas. And I'm also very fascinated with the microbiome. So I hope we have people who ask questions on it, and we look forward to more about the in different spectrum of disorders. So I think the questions have started coming through. Very good. The first one is from Richa Srivastav. My question is related to autism. As you rightly said, the gut dysbiosis is prominent in such cases, and modulating it becomes important. However, any dietary modification becomes a challenge for to selective eating patterns, and the level of compliance required for KT might be difficult to achieve. So success of KT becomes difficult to achieve, and in fact questionable in ASD. Please share your views on the same. So you're muted, Dr. Nathan, you're muted.
Yeah, thank you for asking that very involved thing. Very involved question. We've been using it in autism. Yes, it's very difficult, but I think once you listen to Omnia and to my dietitian, who will speak to you on how we do it, you will realize that yes, it is doable. See, any dietary change is difficult. Any dietary change, whether it is for weight loss, whether it is for whatever. We don't want to change diet because, taste is half of life, or maybe it's in some people 90% of life, and they don't want to change their food habits. So how to do it? It will come across. Dr. Omnia from Egypt and Saima, the dietitian, who is from our center, who handles autism patients, they're going to give you tips on how to do it. So I don't want to go into that, but yes, it works. It seems to work well. It's tough. And it seems to be that if the GFCF, which is very popular for ASD, I think if you can mix the two or marry the two, you're going to get much better results.
Thank you. So the next question is from Utsavi Cheda. Does long-term ketogenic diet affect the cholesterol levels and cardiac health?
Okay, this is important, and I will be taking it up when I talk about, and it will be taken up with the side effects, but I'll just finish it within one sentence. Even in adults, it did rise, but within a year, it always falls back, or within a few months, it falls back. So it does rise in a few. It depends upon what oils you're using. If you use a combination of short chain fatty acid, MUFA and PUFA, then you usually will not have this problem.
And I think our last question is from Dr. Kajal Yepto. Sir, what ratio of carbohydrate and fat should be advised for cancer diet and proteins also?
Yeah, this is also, I will come when I'm talking again on the other uses of ketogenic diet. But yes, you need very high ketones and very low glucose, because basically, as I told you, glucose feeds the cancer, ketones poisons the cancer. Let's look at it that way. And therefore, you obviously need high ketones and low glucose. So we use ratios of, depends on individually. Now that will also come up when we are talking about ratios. You can have a person who will get the same ratio with the 2:1 and someone who will get this, the same blood ketone with 2:1 and someone who will need a 4:1 ratio to get the same blood ketone. So that's very individual. Metabolism is too individual. There's no hard and fast rule.
We have one more question from Aruni Malwat. How frequent do we observe the micronutrient deficiencies in the KD?
Yes, if you do not adequately address those issues, yes, you will, like selenium, like some of the trace minerals. The big one is calcium and maybe B12, maybe B9. So some of these, yes, definitely. But I think most of us, and it will come up, that what are the medications or what are the supplements we give along with the ketogenic, and all of us give it. So all of us are using supplements all the time, and I don't think you will have any problem with micronutrients.
Thank you, Dr. Nathan. I think with that, we will close this session so that we stay on time and we don't fall behind. And thank you once again. And I think that's the end of this session. We go to the next one.
Dr. Shehnaz, who is from Pakistan, she is going to be the moderator for the next session. Shehnaz is now become a very good friend. She invited me to Pakistan to hold a workshop many, many years ago. And she's a professor, head of department, child neurology, Aga Khan University, done a lot of work. And she's the pioneer of the ketogenic diet in Pakistan. So Shehnaz, I hand over the floor to you and I will mute myself.
Thank you very much, Dr. Nathan. And first of all, I would like to welcome everybody to this first conference on the ketogenic workshop on the ketogenic diet. And this is amazing work by Dr. Nathan that he has been able to bring all of us together